All right. Thank you, everybody. I'm Dr. Bryan. I'm one of the infectious disease providers here at WVU, West Virginia University in Morgantown. And so I also work in our Ryan White Positive Health Clinic, taking care of folks with HIV. And I'm also the regional director for the West Virginia partner site of the Mid-Atlantic AIDS Education and Training Center. So we do have a few housekeeping slides that I'm just going to go through quickly. So this program is in partnership with Project ECHO and the Mid-Atlantic AIDS Education Training Center, or MATEC. And those are the states that are covered through our AIDS Education Training Center. And you can see some topics there below of different types of trainings and our target audience, and also a QR code there if you'd like to learn more about us. We are funded through federal funding through the Department of Health and Human Resources under HRSA. We are fully funded through HRSA without any other additional funding sources. Though the contents of this presentation are all from the author or me and don't necessarily represent the official views of any of the U.S. government or government agencies. Again, we are funded through the HRSA HIV/AIDS Bureau. That is the grant funding number there. There may hear some commercial products or brand names listed during the presentation. Doesn't necessarily represent an endorsement, just really for training and recognition. And here again is the area that's covered by the Mid-Atlantic AIDS Education and Training Center, West Virginia, Virginia, Pennsylvania, which is where the center headquarters is, there at UPMC, that's highlighted there in blue, Maryland, Delaware, DC. If you want to learn more about our AIDS Education Training Center or see other events that we might be having, you can go to matec.org and look under trainings and events. We have both live and virtual events available. And we always like to provide folks with some additional resources. So the National Coordinating Resource Center at AIDSETC.org, or also the National Clinician Consultation Center, can provide free peer-to-peer consultation for any patients or clients that you have in front of you at that particular time. And there's also a great national HIV curriculum at hiv.uw.edu. And I believe that provides free CE credits as well. Again, the faculty and staff involved in the planning of today's events don't have any conflicts of interest to disclose, and neither do I. And then once again, that's sort of our headline with our website, phone number, and a QR code if you want to learn more about the ATC. Okay. So that brings us to today's topic. So objectives for today, I want to discuss a little bit about the epidemiology of HIV infection and how that relates to pregnancy. And I am going to focus a bit on our home state here, West Virginia. Identify some of the risk factors for perinatal transmission with HIV, and also the strategies to minimize the risk of HIV transmissions from mother to infant. And then also spend a little bit of time on the current guidelines for HIV management during pregnancy, and a little bit talking about some of the preferred regimens. So here in West Virginia, for the most part, we've been classically a pretty low incidence state for HIV. However, in 2019, we started to have a couple of outbreaks, and this unfortunately has been tied to the opioid epidemic, and with many of these being related to injection drug use. These, the two main counties affected by that were highlighted there in the southern part of our state, Kanawha County, where the state capital is, and also Cabell County, which is where Huntington or Marshall is located, if you're familiar with that. And this has kind of persisted for several years throughout our state, and we've had other clusters identified around the state as well. When we looked at the demographics of HIV in West Virginia, we really see sort of the young adult is really the most commonly impacted population. So that 25 to 34 age group, and then also into 35 to 44 age group are really the most common individuals affected. Mostly in our state, it's been males. About 65% of individuals with HIV are male, but we have at least a third, just over a third of the individuals impacted by HIV infection who are female. And again, when you look at that age group, that's also going to predominantly be the age group of women who are sort of the prime reproductive years. So our state does actually track perinatal exposures. So they do look at the number of infants who are born to HIV positive mothers in the setting of maternal infection. So that's been tracked for several years. So you can see coinciding with the early outbreak in 2019, when we first started seeing some of our clusters, we also saw an increase in infants who were born to mothers with HIV. It has dipped down from there. But unfortunately, in 2023, we actually did have a case of perinatal transmission, which had been the first in the state in the preceding 8 years, again, related to HIV and pregnancy, with that being the primary risk factor for transmission. So fortunately, it's not a very common event, but it is something we want to remain vigilant on. Okay, so perinatal HIV transmission is really the primary route of HIV infection for infants and children. The rates vary a little bit globally. It's around 14 to 40% transmission rate from mother to infant in the absence of treatment or antiretroviral therapy. With antiretroviral therapy, anywhere from 2 to 10% may actually be lower than that if the mother is undetected throughout pregnancy and delivery. We also see almost a doubling of transmission rates with breastfeeding for women who are not taking antiretroviral therapy. So treatment has really had a huge impact on the transmission of HIV from mother to infant. So I wanted to kind of kick things off a little bit with a case. So this is a 28-year-old female with a history of HIV who's coming to clinic for follow-up. And she was previously diagnosed with HIV infection about 6 years earlier. She's currently on treatments with an undetectable viral load and a good CD4 count. She's in a monogamous relationship with her husband of the previous 3 years, and she and her husband are wishing to start a family. And they're coming to clinic today to ask your advice. So if you don't mind typing in the chat any thoughts or comments or questions or considerations that you might have for this couple who are interested in starting a family, knowing that the mother has HIV infection. Sorry about that. And I don't think I can see the chat right now, so.
That's okay. I can read it to you. Kaylee asked, what is the father's HIV status?
Father's HIV status is negative. Great question. Oh, no,
Discuss her concerns, impact of ART on pregnancy.
Yeah, so so that's definitely a good question. So what medications is she on? Is that something we would want to consider for her pregnancy? Is her partner HIV positive or negative? So those are great considerations. All right. Okay. Any thoughts with as far as risk of transmitting HIV to her infants?
Would you discuss like the birthing plan?
Mm-hmm. Yeah, you could. You could discuss modes of delivery. Any other health issues? Nope, she was otherwise healthy. No high blood pressure or diabetes or any other concerns like that. That's a great question as well. So really want to kind of take a full history and physical and any other medications she might be taking that could interact with her HIV treatment. That's a great consideration too. Whether or not she wants to breastfeed, yeah, that's also a great question. So really kind of thinking long term, we're going to get through pregnancy, and then would she want to breastfeed? What would her thoughts be on that? Never too early to start thinking about that and what those preferences might be. Not to breastfeed or pre-chew babies' foods, and then just effectiveness. What's the effectiveness of her treatment? Kind of what her risk might be. Any strategies you could think of as far as decreasing her chances of transmitting HIV to the infant, and also in general, hopefully a healthy pregnancy outcome from an HIV standpoint. U equals U. Yeah, so definitely staying on treatment, staying on, keeping undetectable, taking your medications, her follow-up appointments. Yeah, that's going to be definitely those are going to be the best things that she can do. Let's see. Definitely family network and support. That's a great thought as well. So, you know, is she going to have transportation to her appointments? You know, her family supportive. Should her husband consider taking PrEP? That's a great option as well to decrease transmission to her husband. You guys are doing great. I think you guys could give this talk. Okay. So I did want to touch a little bit on kind of what's happening in this situation, which is preconception counseling, because I think sometimes this can be an overlooked step. So I did want to highlight that when you have an opportunity to do preconception counseling, that's a great tool moving forward. More than half of pregnancies among women in the US are actually unintended for women with HIV. So if we can get them in that preconception period where they're, where they're engaged in care and also with their partners and engaged with their partners in care to really get them thinking about that and what that might look like. So should definitely try to initiate and document for every encounter with women who are of reproductive age or potential, what are they interested in getting pregnant? So if I do have somebody in what I'm seeing in our HIV clinic who could potentially become pregnant, I ask them, are you interested in becoming pregnant? Are you taking birth control? You know, what are your desires regarding that? And I try to do that as non-judgmental a way as possible. I'm not telling them they should or shouldn't get pregnant, but just sort of what are their plans and what are their thoughts on that. So the goals of preconception care would be to prevent unintended pregnancies. Sometimes people feel like they're just not in a place in their life where they want to get pregnant. Optimize maternal health before pregnancy. So if you have a patient who also has diabetes, maybe you want to make sure their diabetes is well controlled, or if they are also having struggling with high blood pressure, make sure that that's under control. And then from an HIV perspective, also make sure that they're on good, stable HIV medications that would be safe in pregnancy. Definitely want to prevent that perinatal transmission, and then also prevent HIV transmission to any uninfected partners during while you're trying to conceive. From a birth control standpoint, just want to make sure that everyone's aware that women with HIV can safely use pretty much any form of birth control in order to prevent pregnancy. So they can use barrier methods. There's no contraindication to that. They can use birth control pills or other hormonal methods, intrauterine devices or other long-acting reversible methods. All of the emergency contraception, all of those are safe to use for women with HIV. So you shouldn't have any qualms or concerns about that. The only thing to look out for a little bit is some of the HIV medications, not too many of our first line ones, but they can affect the hormonal birth control a little bit and make them less effective. So you do want to make sure that you do look at any potential drug interactions, but otherwise from a HIV standpoint, they are all usually safe to use. We always try to also remind patients that condoms will be the only method that would also help prevent any sexually transmitted infections as well, chlamydia, gonorrhea, syphilis, and those types of things. All right, so I'm going to jump into a little bit on as we get into more of the topic of perinatal transmission. So when is HIV transmitted during pregnancy? So it really can happen during gestation, during the pregnancy itself, at delivery, or even in that postpartum period, I think as you all were alluding to with breastfeeding. It has been isolated from HIV has been isolated from fetal blood samples taken before elective terminations, even as early as 8 weeks gestation. So it really does seem that transmission can happen at any point during the pregnancy. And then we do see some differences in the onset and progression of HIV infection, depending on when we think the infant might have been infected. So infants who are infected earlier in pregnancy often will have a more rapid progression to advanced HIV infection or AIDS compared to those who are infected at the time of birth or closer to birth and may have a more prolonged survival. So it seems like the earlier in pregnancy that infection can happen, the less well the infant does. So that's why that preconception counseling and really trying to make sure that our patients are undetectable prior to becoming pregnant can be really the best way that we can help ensure a healthy pregnancy outcome. What are some risk factors? So I think somebody mentioned U equals U. So the maternal viral load going on with similar to other modes of HIV transmission is really the biggest one. Then also how advanced the HIV disease is in the mother as well. So what's the CD4 count? Does the patient have a nice robust CD4 count as well as a low viral load? That's all going to be good markers that she will be less likely to transmit. There can be some viral factors, which are a little bit harder for us to potentially control. Co-infection with other sexually transmitted diseases. So that can also create opportunities for HIV to more easily transmit. Cigarette smoking or any drug use during pregnancy can also increase the risk, a lot of times just because it's harder to reliably take medications, and then the inflammation that can be generated from cigarette smoking. Also, of particular note, if a woman is pregnant and acquires HIV while she's pregnant, that's going to be a much higher risk for transmission because we get such a huge spike in the viral load early in infection with acute HIV, as Dr. Swari had talked about in our last one. Obstetric events, so for that intrapartum delivery, so is it a really complicated delivery? Do they have to do any procedures? Is there any sort of like intrauterine monitoring? Anything that's real invasive like that can increase the risk for transmitting HIV during the time of delivery, breastfeeding, and then unprotected intercourse with several partners. So just to highlight again, I think we've showed this several times during this Project ECHO, but remembering that patients who are taking antiretroviral therapy and virally suppressed are least likely, and in this study from MMWR, they effectively had a zero rate of transmission of HIV to other individuals. It's usually the individuals who aren't yet engaged in care, aren't aware that they have HIV, or in care but not yet virologically suppressed. So this is where we really want to keep all of our patients as much as possible. And what's the rationale for that? Again, when we treat HIV, we bring that viral load down, and that is the major risk factor for transmission. The higher the plasma viral load, the more likely for any type of transmission that you will have an occurrence of transmission for any exposure. So when we bring that viral load down, we decrease the chances that HIV will transmit from one individual to another. And this is true in pregnancy. So this slide is really a summary of several studies that have been done internationally, from Zaire to Rwanda to the Ivory Coast, but also French and Swiss countries. And it really was looking at the transmission rate from mother to infant in the absence of treatment. So in the absence of any antiretroviral therapy. And so you can see that there's a bit of a range, but it's probably somewhere, somewhere in the range of 20 to 30% in the absence of any treatment. So how about viral load specifically? So all the studies that have looked at this do find a general relationship of increased maternal viral load, increasing the risk for HIV transmission to the infant. Most studies don't really find a threshold below which no transmission occurs. So when we talk about sexual transmission, we really think about U equals U. If the viral load is essentially undetectable, then there's essentially no risk of transmitting HIV to their uninfected partner. We don't really find a complete threshold of zero, but it does decrease significantly compared to what those other studies I showed you, where the transmission rate was around 20 to 40%. So we do have extremely low risk with that. One of the first studies, early studies in pregnancy, the ACTG-076 study, that one, it was the first one that showed that any ART regimen, in that particular case, it was old school AZT by itself, actually was protective at all levels of maternal RNA. So regardless of the mother's viral load, it did seem to protect against HIV transmission. Here's another one. This is a Bangkok study, again, looking at viral load and rates of HIV infection by viral load. So the orange bars are what was the viral load just in absolute numbers. So the higher as the viral load increased, then the transmission rates increased. So those higher 40% transmission rates were seen at viral loads over 93,000. So pretty substantial viral loads there. Whereas if they were under 6,000, their rates were less than 10%. We can still do better with that than with treatment, but you can see that it does directly correlate with maternal viral load. So what about if it's essentially undetectable or very low? So this is several studies have looked at that. Again, looking at the Thailand Bangkok study, PACTG study, and WITS study. And so they all use different thresholds for what they considered undetectable based upon the technology. But anything even less than 1,000, they effectively were not seeing any transmissions if the maternal viral load was less than 1,000 copies, less than 400 copies, or less than 500 copies. So it really does seem to be the most effective way we have at preventing HIV transmission to infants. So where are we at nationally with perinatally acquired infections? So we had the early age era of the epidemic in the late 70s, early 80s. And remember early on, it was mostly men who were diagnosed with HIV. But as we started to see more women acquiring HIV, we also saw increased rates in perinatal transmission. This effectively dropped off. If you can see here, this kind of drop off here in the mid 90s. And this is where our first clinical trial that showed that AZT was effective at reducing vertical transmission. So after that first study I talked with you about, once that was implemented around 94, 95, we really started to see decreases in maternal to infant transmission. So how do we approach care of our pregnant HIV patients during the antepartum period? So initial evaluation really should include what is the current status of the HIV disease. So what's the current viral load? What's the CD4 count? Is the patient on treatment? How long have they been on treatment? Is it a treatment that we think is going to be safe and effective during pregnancy? So kind of getting an overall picture of what's going on from an HIV perspective. We really use decisions for antiretroviral therapy are really based on the health of the patient, any previous treatment history or tolerability, any known drug resistance based on previous testing, and then really counsel on the risk of transmission to the infant, as well as risks and benefits for breastfeeding versus formula feeding. So what are our goals of treatment in pregnancy? So we definitely want to optimize maternal health. We really want to, we want our patients to stay as healthy as possible, not have any, illnesses during pregnancy or opportunistic infections during pregnancy. We really want to maximize how much we can suppress that viral load so that we can decrease transmission to the infant, and really try and prevent perinatal HIV transmission. We also want to prevent horizontal transmission to any sexual partners, and then also avoid any maternal or fetal toxicity from medications. So in general, one of our sort of some general principles, in general, women with HIV who are already on treatments, who are already on antiretroviral therapy, in general, we try to continue the current therapy during their pregnancy. As long as they're tolerating it very well, they're able to take it without any issues. It's something that's been determined as safe in pregnancy, and it's effective at suppressing their viral load. So if it's working for them, for the most part, we will try to continue it. One of the reasons for that is we try to discontinue or switch medications that can sometimes result in a small rebound in the viral load just with that switch. And that could create a window of opportunity for HIV transmission. So in general, we do try to avoid that for patients who are stable and already on medication. In general, we do try to have all of our pregnant women on a pretty potent combination treatment, regardless of CD4 count and plasma viral load. That's pretty common, even patients who aren't pregnant. But if we don't sit around and wait for the viral load to get to a certain level or the CD4 count to drop to a certain level before we start treatment, if we have somebody who's pregnant and has HIV, we get them on treatment. We don't factor that in. For women who have suboptimal viral suppression, then at the time of delivery, then the recommendation is that we would also give IV antiretroviral therapy at the time of delivery to decrease the chances of HIV transmission at that point. As far as modes of delivery, so earlier on when we weren't quite as good at suppressing the viral load, we did find that C-section delivery for patients could actually itself decrease the risk of transmission at delivery. How protective C-section is on top of patients who are well controlled on treatment isn't really known, but it seems like it's probably if their viral load is under 1,000, it's probably not going to offer a whole lot of benefit. So they when they looked about 366 women across 4 studies, they only saw 1 documented case of HIV transmission among women who were taking medications that had a viral load of less than or 500 copies. So pretty rare event. So the overall consensus is that a scheduled C-section just because of HIV infection is unlikely to reduce that rate even further. And it does expose the patient to a more invasive procedure, potentially a longer recovery time. So in general, for patients who are very well controlled with their HIV medications, we don't recommend C-section unless there's an obstetric indication for that. And so these are the guidelines. I did provide a link to them as well for the perinatal guidelines, and it just kind of summarizes in a table format what I said. So at the top, if the patients have a viral load less than 50 copies and they're on treatment and they're adherent to their treatment, there's really not they don't require any IV AZT, and they can deliver vaginally or however the OB doctor thinks is the safest and most appropriate for them. If they're at that 50 to 1,000 copy mark, that's sort of the gray area, mostly for the IV AZT, IV zidovudine. So some people might still do it just because there is that low rate of transmission, but in general don't have to. And then if their viral is over 1,000 copies, then the IV zidovudine is recommended, and you can consider scheduled C-section potentially. So what about prophylaxis for the infant? So I'm not a pediatrician, so this is my full disclosure. I do not take care of infants, but that is a component of helping to prevent transmission. So currently, all infants who are born to a mother with HIV infection should be provided with prophylaxis following birth. The duration of the prophylaxis and how many medications are recommended really kind of depends on what the mother's status was prior to delivery and at the time of delivery. So for mothers that were doing really well on treatment, had a viral load that was undetectable, those infants don't necessarily have to have a long course of post-exposure prophylaxis, but it is still recommended. So for those low-risk infants, they would just get 2 weeks of zidovudine. If the mother's viral load was sort of in that kind of in-between zone, then they might potentially do a 3-drug regimen and go up to for anywhere from 2 to 6 weeks. So, but just as a general concept, we do infants who are born to HIV positive mothers should receive post-exposure prophylaxis at the time of delivery. As far as monitoring the infant going forward, so all infants who are born to a mother with HIV should have serial testing. A couple of comments on testing. So we do not recommend the standard screening test or antigen antibody test for those infants because they could still potentially have maternal antibodies that are going to trigger those tests to turn positive, even up to 18 months or a year and a half of age. So really when we're screening infants for potential perinatal transmission, we really are looking at talking about PCR testing or nucleic acid testing for those infants for that screening. If they were born, the risk level of the transmission really depends on the viral load of the mother starting around the 20-week mark. If it was a higher risk infant, then screening should be done at 2 to 3 weeks of age, at 1 to 2 months of age, 2 to 3 months, and 4 to 6 months. If the mother was very virologically suppressed and it was a lower risk, you don't necessarily have to do it quite as frequently. For breastfed infants, because we've had a change in the guidelines, some of this is a little bit in flux too. I don't know if there's anything currently hard and fast, but they are tested throughout breastfeeding as far as they do every 3 months throughout the breastfeeding period, and then up to 6 months once they've stopped breastfeeding. So they do that will be extended if the mother happens to breastfeed. So as far as obstacles to overcome, so we really need to kind of continue to, we are seeing continued increases of HIV infection among women of childbearing age. So that increases the potential for pregnancy and potential for perinatal transmission. We do have challenges of delayed or lack of prenatal care, particularly in women who happen to use illicit drugs or aren't well engaged in care. As I mentioned earlier, acute or primary infection late in pregnancy or in women who are breastfeeding can be some of the highest instances of transmission that can occur. And then lack of full implementation of routine universal prenatal HIV counseling and testing. So summary, so perinatal transmission has fortunately decreased significantly throughout the US due to our advances in medical care and effectiveness of our treatment. But as we're seeing here is still in West Virginia, we do want to continue to be vigilant because it is still something that can happen. Our most effective tool to decrease the rates of perinatal transmission, again, is that virologic suppression and keeping all of our patients with HIV infection on treatment with a suppressed viral load throughout their pregnancy and the postpartum period. And then infants who are born to mothers with HIV infection should receive prophylaxis at the time of birth with the duration and timing and specific medications depending on what the risk factor was from the mom. And with that, let's see if we have any questions or comments or experience that other people's had. Yeah, Jen.
Hey, thanks for the talk. That was really helpful. I had to join late because of a patient, so I might have missed, I know I missed some things, and so I apologize if you went over this. My question is about breastfeeding. Can you just review for me what the risk of transmission is with breastfeeding, and does it make it difficult to convince someone to breastfeed even if the risk is very low?
So yeah, that's a great topic. I think we might do a Project Echo just related to breastfeeding, but the guidelines around this have changed. Just in the past, I want to say it was 2023. But correct me if I'm wrong, if anybody's more up to date. I think it was around 2023. The guidelines around it changed. So it used to be full stop. Women with HIV infection should not breastfeed. Period. Full stop. End of sentence. Should not happen. In the US. It was 100% bottle feeding. And then they really kind of looked at those guidelines and said, oh, thank you. Somebody checked me. It was Curly 2023. Thank you. Appreciate that, Jared. But they really looked at it and said, there are benefits to breastfeeding. There's benefits to the mother. There's benefits to the infant. And while that risk isn't zero, it is pretty low. So the guidelines switched toward the conversation of shared decision making, where the recommendation is you say, okay, the risk of breastfeeding your infant is low. We can't say it's zero. I think the estimates from the CDC are currently around anywhere from around 1%. And then of course, the longer that you breastfeed, that risk, the more substantial that risk can be. But it is pretty low for women who are taking on treatment with an undetectable viral load. So that's where shared decision making comes in. And I think really, as far as counseling patients, it's saying, okay, here there are some benefits to breastfeeding. And this is what they are. And here's, versus, the risk. And then you just sort of let them kind of sort of decide. They do pretty strongly recommend against anything like, reporting to Child Protective Services, somebody, who has well-controlled HIV, and is making the decision to breastfeed. So that's one area where I don't know that they're super settled is how long do you continue infant prophylaxis for breastfeeding, because that's sort of a newer area because those guidelines just changed. Before it would be like, well, you just do your infant prophylaxis and then you stop. So I think that's something that the pediatric realm might be struggling with a little bit. If the mother's undetectable, does continuing infant prophylaxis a little bit longer potentially, mitigate even that 1% risk? And I don't know that that's super settled right now. If anybody has any more experience with pediatrics or some of that, but hear from our pediatric ID colleagues and just kind of some things that are out there, there might be some providers who would continue infant prophylaxis a little bit longer or through that breastfeeding period. Definitely would need to extend the screening of the infant.
Yeah, that's interesting. That was my next question. Thanks so much.
Yeah. Oh, did Lawrence have your hand up?
Oh, yeah, just a quick question. Great presentation. And you might have gone over this already, but just wanted to get your recommendation in terms of delivery and what kind of conversation do you have with your clients when it comes to those women that are HIV positive and whether or not they should have vaginal delivery or whether they should have a cesarean section?
That's a fantastic question because that's a that's always a big point, right? We really are, our patients more and more when if plan for delivery, they want to have their birth, have birth plans in place. So for patients or clients who are undetectable, have been undetectable throughout pregnancy, are undetectable up until the time of delivery, it's they can have a normal vaginal delivery. In fact, the guidelines actually favor doing that. So it's really up to the OB doctor, if there's an OB indication for a C-section, for whatever reason, based on, fetal positioning, they're like, no, we need to do a C-section based on how the baby's positioned. Then it's really up to the OB doctor, as long as those patients are undetectable at the time of delivery. If they're not, if they do have some viremia at the time of delivery, particularly if they go over that, 1,000 copies or more, then the recommendation is that C-section could help prevent transmission to the infant, and then the guidance would be to go ahead and do a C-section because of HIV, even in those individuals, if that makes sense.
Great, thank you.
Any other questions or comments?
Yeah, just one comment again, Lawrence Bryan. Perhaps in the future we could have something around neonatal abstinence syndrome.
Oh yeah. Around neonatal abstinence. Yeah, that's definitely unfortunately something that we've seen here with the opioid epidemic.
Great. Thank you.